let's
begin.
go.
Cool.
Yeah, hi, welcome everyone. Thanks for joining. So welcome to the second of our Spring into Scribe webinar series. So just to share, we're going to be recording this session, and a recording will be sent to everyone who's registered to attend today. If you missed last week's session where we talked about getting to know Scribe, a recording of that is also available online. So today we'll be talking about Scribe governance, and we've got a very special guest joining us today to talk us through that. So let's introduce the panelists today. So I'm Maggie. I'm working in medical operations in Tandem. Tandem is a company that's partnered with Accurx Scribe to provide Accurx Scribe powered by Tandem, so the AVT function. And we've got Osman and Faris, our special guests today. I'll let them introduce themselves.
I'll kick off. So I'm Osman. I'm a GP in London and a clinical team member for Accurx as well. Faris.
Yeah, and I'm Faris. I'm a GP partner in a surgery called St Wolfston Surgery in South Warwickshire, and I also do some health tech consultancy work as well.
Lovely, thank you both. Okay, and just to let you guys know as well, so this is, as I mentioned, part of a series of webinars that we're running this month. So last week it was Get to Know Accurx Scribe. This week, obviously, is Scribe Governance Simplified. Next week, we'll be talking about building a business case with another special guest. And then the week after, we'll be talking about template builders. So please feel free to register for those as well. And also to call out, we've got a in-person workshop day happening on the 23rd of March in the Accurx office. So that will be on leveling up your clinical documentation. We'll be talking about how to use Scribe, different use cases, template builder, all sorts of fun things. So please feel free to register and sign up and join us for an in-person day. Lovely. And we'll talk about that at the end as well. Okay, great. So just handing over to Osman then.
Yeah, so we're going to kick off with a Mentimeter to start with, just to go over a few things, just to get to know who's in the room effectively with us. So let me just switch these screens around and we'll get you up onto Menti. So here we go. So the first thing is just to sign up. So scan the QR code or just go to menti.com and put those numbers in 26958364. And let's get you all in, and then we'll commence this. And just keep it on throughout the session, because we're going to dip in and out of the Menti during the session today. So we've got a lot of you joining. Just give it another few seconds. You can always join in. The code will be at the top of the screen. Okay, so let's ask move on to the first question. So Maggie, do you want to go through these?
Yeah, so first question is, when you hear ambient AI clinical documentation, what governance concerns come to mind first? So please put in your answers and then we'll see what comes up. Lovely, first answers. Okay, great. So we've got a little nice word cloud going just to see the common themes. And you can see a big one seems to be consent, which is something that often a lot of people do mention and they talk about when talking about using an AI scribe. Where's everything stored? Yep, a lot of work. Data protection, how to navigate, privacy. Yep, safety. GDPR, very good. DCV 0160, very good. So we'll be covering that today.
Excellent.
And then where's the data stored? Lovely.
Okay.
Okay, and then moving on to the next question. So what stage is your organization at with ambient AI scribes? So you've got 4 options, so please vote for where you guys are at. So there's already using them in practice, piloting/testing, exploring procurement, or not yet considering. Okay, very good. Okay, so interesting. Lots of exploring procurement already. Nice, okay. Interesting. Very good.
Okay, so we'll head back to the presentation. So I'll just switch back the slides.
Lovely. Okay, so I think the slide really speaks for itself, and this is just a very quick spiel about, why AI scribes and what the impact is essentially. But as you can see at the title of the slide, really, it's estimated that NHS staff spend around a third of their time on admin, and that means time away from patients, away from reflection, and it means routinely playing catch up with all the paperwork after hours or in between appointments. And that obviously leads to this large admin burden, which contributes directly to work dissatisfaction, can lead to burnout, to inefficiencies, and obviously increases the likelihood of patient harm and error as well. So the question is, what can we do about this, and what can we do to try to lessen this burden and make this process more efficient? So this is why we're bringing in Accurx Scribe powered by Tandem. So Scribe is an ambient voice technology that uses AI to transcribe audio from a patient consultation or dictation. So essentially it listens in on the background, it transcribes that live, and then summarizes that into a structured note that can then be reviewed and then saved to record, and can then also be used for any onward communication, such as generating referral letters or patient messaging. So the idea really is that it automates a lot of that note taking for you. And the impact of that is beyond the pure transcription of it. We really see for clinicians that use this tech, we see the impact is really threefold. So for patients, it means they basically get their doctor back a bit more. It means that you can focus fully on the patient and not on the computer, not typing when you're seeing a patient. And that means you can spend more time talking to them, more time making eye contact, and picking up those nonverbal cues, which are so important for clinical communication. For staff, it reduces the cognitive load. It means less multitasking when you're seeing a patient. And we see with clinicians that use this sort of technology that they can cut the time that they spend writing notes up to 90%. And it just makes that note generation and documentation process much easier. And then for the health system more broadly, it means it enables better coordination across care teams by streamlining the admin workflow. And it means that the information can be summarized and shared much more standardized in a much more standardized way, essentially. So very, very briefly about how Scribe works. Hopefully most of you would have been there last week, so you'll know this already. But for those who don't, how Scribe works, it's basically it's built in directly into your toolbar. So you click on that little microphone icon, it'll start up Scribe, and then when you click the start button, it'll listen to your consultation, capture that full thing, and that's whether it's face-to-face on the phone or over video. It does real-time transcription, word, speech to text, and then when you're done with the consultation, it will take that full thing and make it into a structured clinical note. We've got different templates that will determine the structure of your downstream note and what information is captured. And once you're happy with it and you've read through it and reviewed it and made any edits, you can then save to record with our one-click save to record into EMIS or System 1. And then from there, you can create any documentations, send onwards via patient messaging, etc., etc. But enough said. With all that said, moving back on to the Menti, and I'll hand back to Osman.
Okay, so I'll get the final Menti for this section up here. So again, most of you are still there. So let's continue with the next two. Focus more on governance. So which governance approval do you feel is the hardest when introducing an ambient scribe? So where have people felt the pinch points? So information governance, GDPR, clinical safety, procurement contracting, or clinical engagement. Okay, so all in the right place for this session. So focusing on information governance and GDPR. Okay. And the final one is just to do. So ranking these, there's several risks out there. So what would you feel are the biggest concerns of all of these with ambient scribes? And just rank these from highest to lowest. So you can just drag these into order and click submit to see what you would feel would be your highest to lowest concerns. Okay, so yeah, so incorrect clinical documentation seems to be the biggest one, and then data protection GDPR. Okay, and there's a bit of change happening as people answer these. So yep, okay, so data protection GDPR seems to be the biggest one over incorrect clinical documentation, and then consent transparency. Okay, overlines by clinicians, that's really interesting, that being quite low down. Thank you all very much. Okay, so without further ado, I'm just going to hand over now to Faris. Let's get you there. So welcome.
Excellent, thank you. And yeah, really interesting to see people's concerns and thoughts on the previous slide. So that's really interesting. So hopefully, I'm going to talk from my perspective in terms of the governance around implementing AI in primary care, more specifically around AI scribes. This is going back to my experience of implementing a governance procedure and process within our practice, how we did it, what we did. And the good thing with doing this right now is any IT solution that you pick up or use in the future, you really need to be doing a very similar governance process. So this is a really good opportunity to really understand what we need to be doing from a governance perspective, and actually creating our own systems in-house within practice, so that when the next great piece of technology comes, we'll already have a pathway for how to deploy that in the real world. So this stuff is really important, and I hope I can break this down and make it a little bit easier to understand for you. So yeah, next slide. Okay, so why does it matter? So it matters because the governance is looking around patient safety. We need to know whatever technology we're bringing in is safe for patients. We have to identify that risk, see if it's significant or not, mitigate any of those risks, and see whether we've got a satisfactory risk at the end of it. Data protection is really important. We have a responsibility to protect patient data. So we really need to do this process to understand data flows and identify any risks that might be associated from a data protection side. And it's compliance. We have to do this stuff. NHS England's made it very clear that if you want to use an ambient AI scribe, the governance needs to be solid, and they've delineated what that involves. And that's hopefully what we'll be covering now. So it's all a bit complicated. So I thought, why don't we break it down with an analogy around a child's seat? Now, a child seat is not by default safe. It might be safe from its construction when it's being tested in a specific environment, but if you don't connect it to your car, it ain't going to be safe. And if you don't strap the child in, it's certainly not going to be safe. So a child seat's a really interesting way. So what I've tried to do is just link the bits that we're doing from a governance perspective here to a sort of real world analogy around the use of a child seat. Now, it might be slightly tenuous, forgive me if it is, but hopefully it might help. So the child seat, when you're in the store, you might be in Halfords or wherever, you're looking to buy a child seat, you need to know that that seat has gone through the appropriate testing that a child's car seat needs to go through. And that might be things like CE marks and other regulatory approvals that mean that that seat is safe to be used in the UK. Probably the retailer will have checked that anyway to make sure that whatever they're selling is safe, but you need to make sure that that child seat that you're purchasing has gone through the appropriate testing. And that might be the equivalent of what we call DTAC when it comes to digital technology. That's making sure that all the things that should be done have been done to create that product. Then you need to know or know how safe that seat is in your specific car. Does it fit? Have you got ISOFIX capabilities in your car? So does the seat fit? And you might think about that in a DPIA way, data protection impact assessment. We're essentially saying, does this technology continue to preserve patient data appropriately? That one may be slightly more tenuous. Do I know how to use it properly and safely? You know, I might put the child seat in, but have I done it properly? Because this seat is only going to be safe when it's connected safely and appropriately. So I need to know that I'm doing it properly. I need to know that there's no risks associated with me using that child seat and that I've done it right. And that's kind of like what the DCB 0160 is. It's making sure that we've identified any risks and we've mitigated them to make sure that we are using this as safely as possible. And then, do I actually use it properly and safely? Do I actually connect it properly? Do I actually use it correctly each time? Well, that's where implementation comes in, and we'll talk about that later on. So we're ready for the next slide. So key governance prerequisites, and I've called them prerequisites because these are things that you won't be involved in, but these are the things that mean that this is okay. This child seat is probably safe to use if I use it properly. And for digital technology, there's probably a few areas we look at, but there's 4 very specific ones. So DTAC. So DTAC is looking at the patient safety side of the product, whether any risks have been appropriately mitigated, whether data is processed appropriately, whether the product is interoperable. So it's a series of requirements that NHS England has on new digital technology products coming into the NHS. So you want to make sure that whatever you're using has got DTAC. You want to make sure that it's GDPR compliant, because because we have a responsibility to make sure that data flows are safe. Medical device class is important, and the MHRA are basically responsible for this. But what we need to make sure is that the product we're using has a medical device classification that matches its risk and matches its purpose. So this could be class 1, it could be class 2A, it could be class 2B, depending on the potential risks associated with the product. So you just need to make sure that the product that you're looking at, in this case a Scribe, has the appropriate medical device classification to match the risk that could be associated with its use. And the last thing is cyber essential. So all digital technology products should be cyber essential, signed off to make sure that the technology itself is safe and secure. So those were the prerequisites. You don't need to get involved with those. You just need to make sure what you're looking at has ticked those boxes and you're satisfied with it. Now, this is where our governance comes in. So this is the process that a GP surgery needs to follow in order to safely deploy a new digital technology solution. And again, in this case, the Scribe. So the first starting point is the DPIA, the Data Protection Impact Assessment. And what we're doing with that is really understanding patient data flows and making sure that patient data is preserved and looked after and is managed in a way that's compliant with UK GDPR. So that's what we have to do first of all. Once we've done that, we have to update our privacy statement as a practice, as long as we're content with the assessment that was made in the DPIA. As long as we think that the data has been managed safely, we can update our privacy statement. And that privacy statement is essentially telling patients what happens to their data. So whenever we're working with new digital providers that might be processing data on our behalf, we have to update the privacy statement so that the patients and users of our service are aware what happens to their data. So that's a paper exercise almost. And then the next thing is the DCB 0160, which feels like the big beast of this process. But it is time consuming, it is challenging, but it's really, really rewarding when you do it properly and when you do it well. And we'll talk about the DCB 0160 shortly. But the most important thing is, well, one of the most important things is you will need a digital clinical safety officer to undertake that piece of work for you. And that might be done at an ICB level with the named digital clinical safety officer, or it might be done in practice. But you do need that person to do that for you, and we'll talk about that shortly. And then the last step of the process is there's no point doing all of that if you do a rubbish job of rolling it out. So we need safe implementation. Staff need to be onboarded properly. We need standard operating procedures to make sure staff are fully aware of how to use the software safely and properly. And then we need to audit how well that's going and whether people are actually following process or not. So the DPIA and the privacy statement. So as we've said already, the data protection impact assessment is essentially looking at what data is collected, where does it go, how is it processed, and how is it stored. So this is quite challenging, and we found this challenging when we did this work a year and a half ago, because you really have to understand with AI, where does the data go? So where are the servers? What data is flowing from the practice to the server? What is being stored? So you need to really understand that. And that took us a while to really understand at the start, but actually it's not too complicated. And Accurx and Tandem will obviously be able to help you understand those data flows, but you can't do a DPIA without understanding those data flows so that you're confident that the data is being processed and stored in a safe way. Once you're content with that, and once you're content with the data protection impact assessment, and you're content that data is looked after appropriately, you will then need to update your privacy statement so that patients are aware that you're working with a third party that is processing data, and that privacy statement needs to reflect that. And as we've said there, this is all about, is patient data being kept safely? So now the DCB 0160. So not the data this time. This is now about patients, and are patients being kept safe? And that's what the DCB 0160 is seeking to do. It is the companion to the technology provider's DCB 0129. So that's the risk assessment they will do as part of that DTAC that we talked about earlier. They will generate similar sorts of documentation around their DCB 0129. So when we come to do the 0160, we've got a really good starting point. We've got the work that they've already done done on the 0129. We already can use the risks that they've identified, but what we're trying to do is interpret those risks in the real world, within our organization, with the nuances of the way our organization functions. But we're also looking to identify any additional risks that they may have missed that are, again, nuanced around the way that we're going to be using the technology at an organizational level. So the first thing is we need to appoint a digital clinical safety officer. If you haven't got one, you could train one. And the NHS does provide really good training for digital clinical safety officers. If you're contemplating going for it, I would encourage people to. I've done it myself, and it's actually allowed me to be safer, not just from a digital side, but actually across practice. I feel more capable and competent now writing processes and protocols and standard operating procedures across all aspects of the surgery now, because I've kind of heightened that awareness of clinical safety, what it means and what we need to do to make sure it's preserved and enhanced where we can. So you need your clinical safety officer, and then your digital clinical safety officer is responsible for completing the clinical risk management file. Now, this file contains 4 what we call deliverables, or documents that need to be created in this process. The first of those documents is the clinical risk management plan. This is essentially delineating, highlighting the process that we go through within a practice or an organization to ensure digital clinical safety is looked after, is maintained within the practice. So it's basically highlighting the process that we're going to follow. Then we need to complete a hazard log. The hazard log is looking at the risks that we can identify, either those that we've taken from the 0129, and additionally any other risks that we've identified from a practice level. And what we need to do is understand what the clinical risks are of this product and what we can do to mitigate those risks. And at the end of that, we'll have to understand what is the outcome risk, what is the final risk of those items. That then feeds into the clinical safety case report. The clinical safety case report essentially says we've looked through the hazard log, we've identified various risks, and essentially gives a narrative around how significant those risks are. Essentially, does the product represent a risk that we cannot mitigate and we cannot accept? If that's the case, then we can't then sign or approve this product. If we can mitigate those risks and we think those risks are acceptable, then we can make that recommendation in the safety case report. And then after that's done, we need an incident management log to ensure that we have a sensible way of reporting safety incidents and concerns, and then feed that back into the process. And that is the process around the DCB 0160. It sounds a lot more scary, I think, than it actually is. So then it's safe implementation. You've done all of that work brilliantly well. You know what you're dealing with, but the proof is always in the pudding. It's always what you do on the ground in the real world that matters. You can write as many documents or do as much prerequisite work as you want. If the people using it don't use it properly, then the outcomes aren't going to be safe or acceptable. So safe implementation. How do we use the AI Scribe safely and properly? And what we've broken this down into four segments. Onboarding. So does everyone understand why we're using the tool, how the tool works, how to use this tool safely? We also need a good standard operating procedure, a clear process that makes it very simple for people to understand how this tool should be used safely. For example, all outputs from the scribe need to be checked by a clinician. So in the standard operating procedure, it's really important to say, before saving your record, ensure you have read your notes to make sure you are satisfied with their content. Very simple thing to do. It will form part of your risk assessment in the DCB 0160, and the standard operating procedure basically supports that process, making sure that people are doing that checking to make sure what we are saving is correct. Then we need incident management reporting. If someone feels there's a risk to using the product or they've had a negative outcome, then we need a way of reporting that back. And then we need to be able to audit. How do we review if people are using the tool correctly? And how do we identify any concerns that are raised from that? So auditing is our way of making sure, looking back at records to make sure the records contain what they should contain and to make sure that appropriate process has been followed, which essentially means that the product has been safely implemented by those who are using it. And there we go. Thank you very much. I hope that was useful.
Well, thank you very much, Faris. That was really enlightening. I think the key things to highlight is actually the process does look scary and long-winded, but actually once you start getting into it, it is very much a process just to follow through, and it isn't as scary once you're in there. And I like the point you made actually around becoming a CSO or going through the CSO training can help you within the practice all round, and I think that's a really keen take-home point for me as well. And there's some other questions that are coming through, which I'll come to. So some of which will be answered in some of the following slides that I'm gonna focus on. So I'm just going to quickly go through some support and assurance that is provided from the Accurx side, and then I'll open it up to questions. We've left quite a bit of time just to go through those, and there's some really interesting ones that we'll come to shortly. But I think, yeah, as Faris mentioned, this is very much the focus of the presentation here around governance, because we know it's something we can do to make ourselves work better, work faster, but we're often too busy to stop to change the wheels and to take the time out to do the governance in the way it should be done, and you know, get the CSO type of work completed as well. So it's very much around actually let's make some time to actually do this, and coming to this webinar is just one of those ways that you've taken the time out to actually change those wheels. And again, as Faris mentioned, here at Accurx, we're really focused on being safe, compliant, and assured, and we've gone through that prerequisite DTAC process. And Accurx Scribe is integrated with the whole suite of solutions that we provide with privacy and security by design, and in line with all of the NHS governance and data security and clinical safety standards. And just as a additional point, with the ambient scribe itself, it doesn't store audio or use the patient data to train its AI. And all of the resources, so the DCB 0129 and the hazard log and the heavy lifting that we do here at Accurx, are all available on the Trust Centre. And we're going to send all of those who've been on the webinar today the links to all of these. So you'll be able to download the DPIA that we've got, the DTAC that we've completed, and also the DCB 0129 and our hazard log, which then you can use to do your own clinical safety on. So we've done a lot of the heavy lifting from our side with the DCB 0129, and we've filled it in and completed that with a view that actually when it goes to practices, PCNs, ICBs who are looking to complete the 0160 on their side, they can do that in a straightforward way with as much support. And as well as the products that we've provided the documentation for, we've also provided quite a lot of templates. So there's the template for the DPIA and also the clinical safety case report to go hand in hand with the hazard log that you can then use to sign off the governance from your side as well. Faris also talked about the privacy statement and to make your patients and users aware of the product. And again, we've done a whole load of work with putting together some resources. So we've got some FAQs for your patients. We've got posters and things you can put onto your TV screen. Also model text for your privacy notice to go on your website. So all of that is also available. And again, we'll share these resources with you. And we also know once you've gone through all of these documents, there's always this thing about actually at the last minute that there are some things that I just want some personal advice on, just for my practice or organization. And so what we've also done is we've created these clinical governance drop-in sessions where we've got a clinical member from the Accurx or Tandem team who will be able to answer your queries. So one of our clinicians can talk directly to one of your clinicians or practice managers to actually get on top of any sticking points that you're going through. So there's a lot of support that we've done to wrap around just to really help support practices feel comfortable and confident that they're doing this in an assured way and safely. And this is all with a view that you can then go on to access a really powerful scribe directly from the toolbar, and in the Accurx way make it really easy just with a click or two just to get in and do something that will really help with your consultation. And as part of what we're doing with this whole Scribe series in March is that we've got a a chance to win 12 months of free Scribe for your practice, and the chance to win is to do 200 consultations across your practice. If you're saving those directly to the records throughout March, you'll be in with a chance to win 12 months of free Scribe. So we've got all of that offer, and we'll send this out to you so you can have a more of a deeper dive and discussion within your practice. So that's the presentation. I'm going to open it out to questions now. Let me just take the sharing off for now, and we can come on and have a look to see what we've got. Really good, really interesting question here that we get often, and I'll open it out to Faris, Maggie, and to come in. So this is all around the hazard log. So we've got the product hazard log. So the 0129, we've got the hazard log there. Then it goes to the 0160, and the practice organization needs to complete the hazard log. So the question here is, ours is extensive, the hazard log, but I feel like I could add infinite hazards based on so many circumstances and situations, which is a really interesting question, I think. So Faris, you'll come in first on that one?
Yeah, I mean, ultimately, the more you find, the better. I mean, the idea of that hazard log is to really identify anything that you can pick out that could cause patient harm or be a risk. So the more you find, the better. You might find actually there's some overlap between those, because very often there's a bit of commonality between some of those scenarios that you might identify. But look, I mean, being thorough, being rigorous is really good and really sensible. So if you can pick out loads, then certainly pick out loads. You'll probably find with the AI Scribe that a lot of the concerns or risks will be mitigated simply on the basis that the GP or the clinician should be checking those records and those notes that are being completed and produced. But yeah, certainly if you can find lots, then put lots, and the more you can mitigate, the more you can feel comfortable and confident that you're delivering something that is as safe as possible.
Yeah, thanks. I totally agree with that. Maggie?
Yeah, absolutely. I think it's a very good point that a lot of them will have commonalities. It will be a lot of different circumstances that lead to quite similar reasons that they might have caused something. So absolutely. And it's also the benefit of doing that exercise, and that gets you thinking about the ways things can go wrong and the mitigations to put in place to make sure that it's being used safely. So that exercise in itself and being in that mindset is really helpful as exercise anyway.
Yeah, and I think as clinicians, we're always looking at, worst case scenarios and things that can possibly go wrong. But if you look at the hazard log, it's there to think about actually what could go wrong, and documenting it is always good to then say actually what's the chances of this actually happening, and then what are our mitigations. A lot of it does come down to awareness and training often as well. Okay, how long would it take to do from scratch? Okay, so Yogesh has asked about that. So I suppose we all kind of done it for different organisations. So do we want to have a stab at saying, so roughly how long did it take? I suppose we're juggling a whole load of stuff at the same time, aren't we, at the same time as well? So Faris, how long did it take you to go through the process?
That's a good, I mean, that's a brilliant question, isn't it? And then it makes you reflect on how long did it actually take, because you don't quite understand that when you're in the moment, do you? Look, I suppose the big question is, do you need a digital clinical safety officer? And if you do, then there will be the time associated with training there, the online modules that need to be completed, and then the face-to-face section as well. So if we take that out of it, and that's not too time consuming, and it can be done over weeks really. So if we take that out of it, how long does the rest of it take? Well, look, we've got to do our DPIA, our privacy statement. Probably you might want to allow for a solid day's work there, at least maybe a couple of days work, but something along those lines. You'd hope to have it done within a day. When we started, we were early adopters, so we had to do a lot of the figuring out. Now lots of the stuff is already been provided. So I think from what you just said there, Osman, about what's already been provided, then actually, you'd hope to get that done within, I'm saying a day, but someone might shoot me for that. I don't know. The data, the privacy statement, not too bad. The DCB 0160, it just depends on how much you can find. You will need a risk meeting with other members of staff to try and identify the risks that go on your hazard log. But then you'll need to go through those and do some work. I mean, I normally allow, a good 2-3 weeks to go through this process. But in terms of hours, it's going to be really dependent on what risks you identify, what mitigations might need to be put around those, what information you've been given to start with, how easily you can understand the data flows on the DPIA. So there's a lot there. I suspect this probably won't take you as long as you think, because a lot of the material's been produced already. So I think it probably won't be as arduous as it would otherwise have been if this material wasn't already, a lot of this material wasn't already done for you. People will get worried when they listen to the DCB 0160 and go, oh my God, how am I going to do that? But the honest truth is that if the DCB 0129, which the manufacturer does and gives to you, is good, it's going to save you a lot of time, and it will give you really the structure and the skeleton for your DCB 0160, and you will just add a few extra bits onto that potentially. So yeah, not a very good answer, but I think it's quite hard to give you a very strict answer because there's a lot of variables that will be at play there.
Yeah, no, I think that is a good answer, because I think generally when I speak to people around it, it's 2 to 3 weeks is a reasonable, generous amount of time to get it done. And it is, I think the rate limiting step is often getting the hazard log meeting together. So once one of the biggest time consuming things for the 0160 is actually getting people together to say, we've got all the paperwork together, we now need to discuss within our practice, this is what the manufacturer has put down as the mitigation factors for these risks. Do we agree with it? Do we want to change it? Do we want to add some more risks to this as well? So all of that you'll find, and we'll send you the links to what we've put together for the Accurx Scribe with Tandem, and we've looked to really making it as easy as possible to put to practices to utilise really. Anything else from your end, Maggie, in terms of clinical safety?
I think that was very comprehensive. Yeah.
Cool. Excellent. So this is another one that gets asked quite often around who actually does the clinical safety. Okay, so does a doctor need to take on the role, or can an administrator?
Good question.
Yeah. Good question. Yeah.
From the people who I know who do it, from my experience, it's mostly clinicians, but it can be any type of clinician. So it doesn't necessarily have to be a GP, but nursing staff or others could take a role there. The reason a clinician does it well is because it's really understanding what happens at the coalface. It's very hard for you to understand really the breadth of risk with a piece of technology when you're not having the experience of delivering consultations. So the clinician has a really unique perspective where they actually understand what happens, the nitty-gritty on the ground in a consultation. So yes, I think clinicians, but it can be various clinicians that can take on that role. But a clinician is well placed to do that role because they can best sort of analyze and assess and appraise that risk, because they're the ones doing it all the time.
Yeah, absolutely. And I think we often get practice managers who want to know what the process is, but the responsibility of a clinical safety officer is with a clinician. Yeah, you're right. It's any clinician, isn't it? So it's that way. And then there's also within your practice or organisation, if you feel that actually you don't have any clinician within your practice, that there are third-party providers that you could give the CSO responsibility out to as well. So there's lots of different ways that you can do it. The practice itself is always accountable, so they will always take what the CSO has done and has the final decision. But the support of the CSO can be in-house, and certainly you can work your way up to getting one of your clinicians trained or third party really. Okay. So I assume Accurx Scribe has had several updates already. Who decides when it needs reassessment of risks and a new clinical risk management plan due to the changes? Yeah, and I think when data gets updated, and this is where the review comes in. So the post release, you're not, that's not it. You're always looking at actually you'll be notified of updates, of new releases, new things that come in to the product, and it's about actually do we need to reassess the risk based on these and put in more hazards. Or what you'll find is that what we often do at Accurx is that we look at the updates, and then we produce a new set of hazards, and we update our hazard log, and we're just building a way of actually now just automating that coming out to you, rather than just emailing and saying this has been updated, to make it much easier for you to have an updated hazard log produced for yourselves as well. But yeah, you're absolutely right. From a product perspective, we go through that process for you, and that's part of the post evaluation review. And generally every 6 months you should revisit the hazard log. That's generally what we do. I don't know, Maggie, Faris, in terms of your process within your practices. That's what we tend to do. But every clinical meeting, we've got just got an agenda item to say any questions or any queries about the scribe, and then we just log that. And then every 6 months, we'll just go back to the hazard log and just review it. So that's our process. Faris, anything that you do in terms of review?
Yeah, again, the same. We have it's a standing item on our board meeting at the practice. You would want to know, as a practice, if any significant update was being implemented through a software update, and then understand if that has any impact on your DCV 0160 and your hazard log. So the ideal would be that if a software update was occurring, that the clinical safety officers in the practice would be aware of that update in advance. That would be ideal. They could then ascertain if there was any impact on the hazards that we'd previously identified, and identify any new hazards. But yeah, exactly the same. You do need to review it if there is an update that could open up to new risks or hazards, and you do need to constantly be feeding back from staff if any new concerns are raised.
Yep. Cool. Maggie, any other questions coming through from your end?
Yeah, so actually, yeah, so just following up from that question, actually, so someone else has asked, if you release new hazards, do we need to pause use of the product whilst we look at the new hazards? So I don't know what your guys' thoughts are on that.
Yeah, I'm just thinking of a recent example would be something like Template Builder. So Template Builder was a new feature that came into the Scribe. So it's certainly a feature that was rolled out, and practices were informed that this is a new feature. There's a big publicity around that as well. And what we did certainly in our practice was that we said, this is Template Builder. Let's have a look at it and see how it works. And we just reviewed that and looked at. Did we add a hazard? I think we just added one query around the hazard, around actually just make sure you've spoken to somebody and somebody's gone through it with you. One of the lead GPs has gone through it with you before you start creating your own. That was the only real thing that came out of it for us. But you would want to make sure you wouldn't pause the solution as a whole. You probably would pause any new features until you've got agreement and you've discussed it within your practice, really. So that's what I would do, and that's what we do in our practice. Faris?
Yeah, no, that are completely appropriate, really. I suppose, this is about risk, isn't it? And it's about understanding, what risk means and what it is. So you'd want to know in advance if that feature was coming out. You'd want to switch it on if you were happy and you didn't identify any risks, or if you were happy after mitigating those risks. If there was a change that was going to happen that you thought would compromise risk, then you should pause it until you're confident that it's been mitigated. So the onus really, I suppose, is on us as the deploying organizations to make sure that we're always confident or comfortable with risk. And where a new risk is identified, if you feel like that update creates a new risk that you think is unacceptable, then you would need to pause your deployment until you could assure yourself or reassure yourself that you've mitigated that new risk. So constantly the question that you're asking is, does this pose a new risk, and is this risk acceptable, and can we mitigate it?
Yeah, and I think that's probably where it's really worthwhile having on a regular standing item in your meeting to say, actually, anybody want to discuss anything on the AI Scribe did this week? Because somebody will go, well, I've just noticed this, or there's this, and then people will just pick it up in terms of any specific change that they've noted, which would be something to look at. So having that awareness is really, really important.
Lovely. Someone else asked, so does Scribe help avoid capital letters, exclamation marks, veering towards complaint, etc.? I'm not quite sure about that first part, but the second part is, do reminders pop up before the user saves it to record? And the answer to that is yes, there is a safety feature built into the product. So if Scribe notices that you're saving to record too quickly, and we calculate that by, how long it would take someone to glance through it, or you've not made any edits to it, it will then pop up to say, have you read the note? And that's just a safety feature that's built in again to make sure that the clinicians are reading the notes before it transfers to EPR.
Yeah, and that's a really good example of actually, if you look at the hazard log, that's one of the things that we've put in. So the hazard is actually making sure that you've got assurance that it goes back into the same patient's record that you've just done the scribe on, and the feature is, yes, there's a pop-up that confirms the patient, but also a warning, which is an additional feature, safety feature, that's in the hazard log that basically looks at, actually, are you absolutely sure because you click too fast? So that there is that kind of safety in there. Yeah. I think what to describe help avoiding capital letters, exclamation marks, veering towards a complaint. I think Scribe doesn't really put in exclamation marks or things like that. So I wouldn't be too concerned about that side of things.
Another question, which organizations will check that you've implemented this correctly? Is it ICB or NHS or ICO? It's a great question. I'll open it to you both.
Yeah, should I take that first, right? So shall I?
Nobody would be my answer. Osman, I don't know if you've got another answer.
Yeah. So there is the only thing about implementing it correctly. The only thing I've come across is where practices have had CQC reviews. Where the CQC have come through and they've said you're using this technology. How have you assured it? Have you done the DPIA? And in one case I've heard about, have you done the clinical safety around it? So if you certainly look at the CQC, if you look at the documentation from the medical defence organisations, they're very much around, just make sure you're following guidance. And the guidance is, as Faris explained, it's the safety checks, like the analogy of the car seat as well. So around, have you done all of the stuff that you need to do to make sure it works for you? So DPIA and the DCB 0160 are the things that you need to assure. And then, the CQC are probably the closest to us, but the medical defence MDOs are also following that guidance.
Lots of questions about consent, which I suppose came up in the Mentimeter as well in the beginning, but around whether or not you need to take consent every time beforehand and how a patient consent is handled. So, any thoughts?
It comes down to your DPIA. So first, you can tell us how it works at your practice. There's two approaches that we've taken in practice I've seen. So one is consent as a way of just asking the patient before each consultation, and you get their agreement and you do it that way. There's a legal basis I've seen in some DPAs, which is for a public duty. So you're informing rather than consenting. So there's different ways that can be put through, but it should be in your DPIA as to what basis that you're using. Whichever way, your patients should be aware that you're using this, and if they say I would rather not have you use it, then you just don't use it for that consultation, really. Nice.
Yeah, we're of the opinion that we should consent them to make sure they're happy. There's a microphone stuck on the desk. I think if you ignore that, I don't think it feels right ethically. So we would gain consent at the start of every appointment. It depends how you do it. I mean, as a clinician, I've got my tagline, and I say it 30-40 times per day, but I've got a little microphone on the corner of the desk. It's picking up what we're saying and turning the words into the text that will ultimately go into your record. Are you happy for me to use it? 100% yes. No one's ever said no, and I think it's good practice. And then we add a code into the record to say that we've got consent. There's no good code in EMIS, if anyone's thinking, or in SNOMED codes. There isn't anything for this. So there is no ideal code that you can apply that I'm aware of. If there is, let me know. But we found a code that's a relatively close fit that we use in the record. So I think it feels for us like the right thing to do.
Yeah, absolutely. And yeah, and everyone's got their own spiel. It's very, very similar. I'm going to be using this tool to help me, using AI to help me write up the notes. Are you okay? I think I've only had one in the time that I've used it. So yeah, it's very few and far between that patients actually decline. They actually find it's useful. I've found that more patients are now going back and looking at what I've written. I don't know if that's a good or bad thing, but I'm finding that's increased.
And I think it's really important to remember, like, I think that the thing that really stood out when we were looking at introducing an AI scribe was it kind of was that sweet deal between great for the clinician, but really great for the patient too. So I think it's always worth remembering that it's not just us, it's not just our benefit that we're seeking here. Actually, the patients can now go away, see a structured, a structured outcome from their consultation. They can read it. It's a legible narrative without abbreviations that they wouldn't be able to understand. So it's kind of like, I don't know the right term, but democratizing that record, really. It's allowing other people to understand, what do my notes say. So actually, this is great for us as the clinician, but don't forget, this is a really great benefit for the patient. That's what we've experienced. They can now read their records, they can understand what they say, and actually I'm not looking at the computer screen and tapping away on a keyboard whilst they're talking, which would ordinarily be considered very rude, I'm sure. I can now look at them and listen to them, and then they can get their point across and they know I'm listening. So you've got to always remember that actually there is a gain here for the patient too. It's not just the clinician.
Yeah, absolutely. And kind of Maggie touched on that at the beginning of the presentation as well, where actually there are lots of benefits for the patients with using Scribe, and they feel that the clinician has focused on them rather than the screen as well.
Yeah, absolutely. Someone's just asked, what is the consent code that you use, Faris, out of curiosity?
So I can't off the top of my head. It's something voice recording or something like that, and which is not actually that accurate. It's a consent code for voice recording, but the caveat is this isn't voice recording because it is not recording the voice. So this is the difficult bit. It's a consent code, tick. It mentions voice, tick. But actually, it's not actually recording. So it's actually taking, you might be aware, but it's just taking fragments of the speech converted into text. And that's what it's taking. So it's not actually, which is why there actually isn't a very accurate code. The reason a code was useful for us was we could ensure that consent had been asked for. So you can report on that code. So when we do our audit, looking back at patient records, we now have a standard way of being able to identify. So that code really wasn't for anyone's consumption other than our own to say, yes, the clinician is asking for consent. Yes, they are asking for consent. So it was a way that we were reassuring ourselves that people were following the standard operating procedure, really, more than anything.
Yeah, and it's a good example of where actually technology has outpaced how other parts of the system work. So how SNOMED codes are generated and updated every 6 months or so, and we'll wait and see if we get a consent code, because I'm sure it's been requested, and a specific one for Scribe. So yeah, hopefully one will drop. That will be more useful. But you're right. It's that thing around actually how can we make sure that we've got a good process in place.
Another question around CSOs. I think we might have covered this partially, but is there any particular certification, qualification for a CSO, and how often do they have to recertify?
Yeah, so the CSO training, generally, once you've done it, you've got the qualification as a clinical safety officer. I think the value is the amount of tools that you're actually doing it, because it's like a driving test. You can Faris's car analogy. You could get your driving test done, but if you're not driving a car, actually, you're going to be a bit rusty and slow when you do start driving, and the more you drive, the more regular you'll become, and quicker you become, not faster, but you get the analogy. You'll be less rusty at driving. So it's that's the process, really. Faris, have you got anything else to add to that?
Yeah, that's it, isn't it, really? I did the NHS England training, and that was a series of online modules, which probably took a few days or a week of time, with bits of time throughout that week, and then a face-to-face day in London, and that was the that was what was required for the training. As you've said there, Osman, I mean, you can do the training, but until you actually start using it, it's kind of like an unused tool, an unrefined tool. So it's really useful then to start looking at examples where people have done the DCB work before, talk to people who have done it already, look at examples, and then you will refine the skill as you go forward. So the training itself is not too arduous. But like I said, you could, don't consider this a one-hit wonder for a scribe. Consider this a foundational piece of work that will enable you to access digital technology as it arrives more quickly and more safely, and upskill your own ability to judge clinical risk at an organizational level, which will have positive impact on all aspects of your practice potentially.
Yeah, and I think that's the key point. Yeah.
That was a marketing piece for clinical safety officer training, wasn't it?
Yeah, that was. Yeah, absolutely. Yeah. So yeah,
Yeah.
but I think it's absolutely right. I think every organization, and I think I've been speaking to organizations around this, and for practices, if a practice doesn't have one, at least one person within the PCN should be au fait with a clinical safety officer, or at least a process to allow things to start coming into the practices really.
Absolutely. Someone else has asked, well, it's a bit of an unrelated question, but can it translate different languages as well? And yes, so that is a new feature that's been released in Accurx Scribe, so it can support and detect languages, I believe, up to 60, and what that means, it will translate to English. Obviously, however, the caveat being it's not a live translation tool, neither are we officially a translation tool, so you still need an interpreter in the room in order to verify what the patient is saying, and also to ask questions and have a conversation.
Yeah, and if you have a look at the hazard log on the Accurx portal, you'll find is that we talk about this, and where it's got a good use case is where you've got the clinician and the patient speaking the same language, and then they can consult in that language. The output will come into a scribe in English for the record, and that's where it's got really good utility, and that's what's in the hazard log. Cool. Should we take one more, and then what we'll try and do is anything we haven't answered, we're going to come back to, and we'll feed back into a document at the end of the webinar as well. So anything final we can take, otherwise I'll jump back.
Final one, Mark, you've managed to get in under the wire. So if a PCN had a CSO, each practice would need its own DCB 0160 though, and one CSO to cover all the practices would be a stretch for one clinician.
Yeah, so I've seen this work in different ways. So we worked with my ICB, and what we did is that we did an overarching 0160 for the ICB. But then what we said to practices was we localized it for our region. So for Northeast London, we did a 0160, and then we said to PCNs and practices, this is what we feel the hazards are and the implications are. Have a look at it yourself, and you'll need to do your own one, but actually you could just use our one and then just essentially just modify it. So there was less modification to do with an ICB level one, because we'd accounted for quite a lot of the localization and the way that we wanted to have the Accurx Scribe implemented in our region. So that's the approach we took. But you're right, the practices themselves as a organization need to have their own, but it can be that some heavy lifting is done at provider end with the 0129 providing templates, but the ICB may support, PCNs may support, but ultimately the practices need to have their own final one. Faris, how does it work in your region? Do you have a level of doing it, or is it at practice?
I mean, I can only speak personally. We did it through the practice, and that seems like the right place, because the practice is deploying the tool, and the staff of the practice are using the tool. So doing it within practice was, for us, the most sensible thing. I do know that our ICB has completed a DCB 0160 that's been provided to practices locally. What's the right thing to do? I don't know would be the honest answer. Can you safely, I mean, the honest truth is we all use EPRs, which are humongously more risky than AVT, and those DCBs have been done at ICB level, and traditionally practices would barely even have seen that work that was done around safety. So we're into a new era and a new way of doing things, and there's going to be some work that's going to need to be done retrospectively about old technology perhaps that's being used. I think in this case you need to just be sure that you're deploying that technology safely within your practice. If you can do that through a CSO that works across practices at a PCN level, and they're qualified and they've done the DCB work, and you're satisfied that there's not enough variance between the way those practices work, and that you can control the onboarding of individuals within each of those organizations, then you might ascertain that is a safe thing to do and a sensible way to go. So I don't know if there is complete transparency on what is right and what is wrong, but from my side, from a common sense perspective, it really depends on whether what that actually means on the ground, and whether that CSO in a PCN is able to deliver what is required in individual practices. I hope that's helpful.
Yeah, I think that's helpful. And I think the take-home point there is very much actually whoever does the CSO work for you, the practice as an organization has to agree and sign it off. So they are ultimately accountable. So at the very least, you need to read it and agree it. So just don't sign off anything that's been given to you. Just go through it and read it, because actually it does make sense, and it does make you into a better, safer organization overall. So a good time to just move on to the final bit. Here we go. Let's jump back here. So thank you for all those. Really lovely to do those questions, because it really helps highlight a lot of the concerns that are out there. So just as a final Menti, I'll just jump here. So final one here. If you've been logged off, just log back on. So what's your feeling in 2 years' time? So in 2 years' time, ambient AI documentation will be standard in most consultations. So where do you fit along that line of strongly disagree to strongly agree? And there's a few. This is always interesting, because we always get different peaks and troughs occurring here. So it's we've got a peak at the strongly disagree end and a peak at the strongly agree end. But yeah, we're slightly over towards the strongly agree, or getting more so across that way. So yeah, and it is something that's becoming more and more embedded into our consultations over time. And the final question really is, we're running this whole spring series of webinars. If there's anything else that you would like to see in a future Accurx Scribe webinar, just pop it in here. And what we're going to be doing is just reviewing all the feedback from the spring series to see what else would be interesting for people afterwards. So pop something in and we can have a look at that. So I'll leave that running while I'll just nip back to the final set of slides for the presentation. Here we go. Okay, so yeah, just to say that this was the Scribe Governance Simplified with Faris. So thank you very much, Faris, for joining us. It's been a delight to have you with us. Next week, we're talking about the business case and how to build a business case for Scribe. So talking about the roadmap to the return on investment, and how to build that. And we've got Dr. Asad Ashraf joining us for that. So that's next Wednesday at the same time of 12:30. And then in 2 weeks' time, we're doing a deep dive into Template Builder. And Maggie's done a lot of work with Template Builder. And if you've had a look at some of the guidance and the videos we've done on that, you'll know Maggie's put a lot of effort into that. So we'll be doing a deep dive and answering all your questions on that as well. So that's the remainder of our Scribe series in March. And also just to highlight a couple of events that are going on. So level up your clinical documentation. This is mainly for London colleagues, where we're just offering you the opportunity to come into the Accurx offices to just have a look at all things Accurx, and really focusing on how to improve your documentation, particularly using tools like Scribe. And a final plug for Accurx Connects, which is our flagship conference for Accurx. So this is happening on Tuesday, the 28th of April. So if you would like to attend, scan the QR code, and again, we'll be sending this out to you as well. So another date for your diary. So final thank you, everyone, for joining us today for this webinar on Scribe governance, and it's been an absolute delight, and we hope we've covered a lot of the queries and questions you had, and happy scribing. See you next week.
Hey.